Assalamu alaikum everyone. For those of you who don't know me, my name is Mohammed Alfuwais. I'm a fifth year medical student. And inshallah, today I'll be covering the second part of this crash course, which will be the pulmonary part of this crash course. So inshallah, just like all my sessions, this would be an interactive session. I will be asking and you guys will be answering most of the time, and I'll be explaining important concepts. So let's begin firstly with COPD, interstitial lung diseases, and asthma. So the first part of every pulmonary case is a physical exam. There's three things that we look for typically is breath sounds by auscultating, percussion by doing the percussion itself, and fremitus, which is a form of palpation that we do. So first of all, in breath sounds, majority of the pathologies will have decreased breath sounds. Either there's air that's causing obstruction of the sounds that you can hear from auscultation, or fluid in the lungs. If there's fluid in the lungs, the breath sounds are not going to be clear. So in majority of the pathologies, it will be decreased. In consolidation, which is basically fluid-filled alveoli because of an infection or because of pulmonary edema, one of them. In consolidation, there's additional things that you can hear. First of all, there's something called bronchial breath sounds. Normally, bronchial breath sounds are near to the trachea and the sternum. It's basically the proximal airways. The more distal airways are going to be smaller. The sound that's going to be produced is something called vesicular breath sound, and this is in the periphery of the lungs. Usually, when you hear it, it's something that we describe it as vesicular breath sounds. If this turns into bronchial, this is a sign of consolidation or pneumonia. Other than that, you have crackles, which is more specific to pulmonary edema, okay, which is basically, think of it as bubbles that you hear in the lungs. Then agophony and whispered bacterioloquy. These are two additional sounds, most likely for pneumonia. Agophony is basically during auscultation. You tell the patient to say E, it will sound as A. This is agophony. Whispered bacterioloquy basically means is if you tell the patient to whisper something, when you do it auscultation, it will be very loud. Okay, so this is whispered bacterioloquy. On percussion, you can find two things, either resonance on percussion, which basically means there's air, or dullness, which basically means there's tissue or fluid, one of them, okay? In the lungs, it should be resonant, okay, because there's air. If there's fluid in the lungs or collapsed lung, it's dull because there's tissue or fluid. So that's in pleural effusion, atelectasis, which is a collapsed lung, and consolidation. If it's hyperresonant, this just means that there's more air, okay? Typically, that's in pneumothorax, which is basically air in the pleural space, okay? That's why it's hyperresonant. Fremitus is you put your hand like this onto the chest wall, and you basically tell the patient to say something. Usually it's 99, 99. And you basically are assessing the vibration because of the air. All diseases typically will present as decreased tactile fremitus, except one, which is consolidation, okay? Just memorize consolidation is increased. Now, the last thing, which is an additional finding, is tracheal deviation. Now, tracheal deviation can happen either towards a lesion or away from the lesion. If it's away from the lesion, it basically means that there's something pushing the airway or the mediastinum away. Usually it's air or some cases of fluid, okay, such as effusion, okay? So pneumothorax and typically tension pneumothorax, I'll explain that later, and then pleural effusion. The other case is if it gets pulled towards a lesion. This is in the case of fibrosis. Anytime you have some sort of fibrosis, this will pull the trachea towards it. This is, for example, in atelectasis, which can have fibrosis, or in certain cancers, and we'll cover exactly, or cancer, which will cover which type is typically you'll see pulling the trachea. Now, the first thing you do in ILD patients, interstitial lung disease, COPD patients, asthma patients, in terms of intervention, is pulmonary function tests using spirometry. To understand all of this, I'll just explain just the basic physiology of the lung. Is you have these lung capacities, okay? So basically when you're breathing right now, I'm breathing while explaining, for example. This amount of air that I'm breathing is the tidal volume. If I want to inspire all the way, I'm using the inspiratory reserve volume, okay? And I'm using basically the entire capacity of my lung. If I exhale completely, I'm going to exhale the inspiratory reserve volume, tidal volume, and the expiratory reserve volume. This is what we call the vital capacity. This marker, the vital capacity, is very important for pulmonary function tests. There's a bit of air that will always stay in the lung, which is what we call the residual volume. This one, we basically just forget about because we never can calculate this except some certain ways, specific ways, which we won't get into. But there is a residual volume. If we add the residual volume plus the vital capacity, this is a total lung capacity. Now, the important function tests that we need to remember is something called FEV1 and FVC. Okay, what are both of them? First of all is FVC. This is the forced vital capacity. What you do for the patient is you tell them to inhale all the way, maximum, till you can't inhale anymore. So he's inspiring the entirety of the inspiratory reserve volume, inspiratory capacity, until maximum inhalation. Then you tell the patient to exhale maximum, full, all the way, until he can't exhale anymore. This is what we call the forced vital capacity, okay? It's forced because he inhaled all the way and he's forcing it out as hard as possible. This is FVC. The other one is FEV1, okay? FEV1 is forced expiratory volume at 1 second. You basically see the flow that is an exhalation in the first second. These two numbers are very important for obstructive lung diseases and interstitial or restrictive lung diseases. These two numbers. Now, what you do with these two numbers is basically divide it with each other. FEV1 divided by FVC, and the number that you're looking for is 0.7. 0.7 is the usual number. If it's below 0.7, this is a pathology. If it's above, typically it could indicate a certain pathology as well. Okay, so this is the normal lung physiology in terms of the function tests. And this is very important. Remember FEV1 and FVC. Remember these two. In terms of the flow volume loop, same concept that I just explained. You start over here, which is basically you're going to tell the patient to inspire all the way to total lung capacity. Then exhale as forcefully and fast as possible. You take the reading at first second, which is going to be FEV1, and then all the way till he can't anymore, which is FVC. And you divide the two numbers. That's it. This is the normal flow volume loop. There are changes depending on pathologies. Okay. Now that's basically the pulmonary function tests. If I ask you, what is usually the first line imaging modality we do for the lung? What is it? The first line, easiest one we can do. X-ray, good. Chest X-ray. Chest X-ray is the easiest and most likely modality we use initially for any lung disease. There are, for certain indications, we do specific imaging modalities, but usually first line is X-ray. In X-ray, what are you looking for? First of all, start with A, airway. As I said, tracheal deviation is important in certain pathologies. You need to look at tracheal deviation. You see the trachea, it's patent, it's midline, we're good. Then you move to B, which is what I would say bones. Bones here, you would just basically look at the ribs or the vertebra, ignore the vertebra. For your case, just look at the ribs. And specifically what I want you to look at with the ribs is the space between the ribs, okay? If the space is increased between the ribs, this is a sign of a certain disease, and we'll look into that, okay? So that's basically that. Then you look at C, which is the basically cardiac, okay, the heart. And I'd include the mediastinum with it. The heart, we mentioned the heart pathologies in the previous crash course. So what I want you to look at in the context of the in pulmo is mediastinal thinning, basically compressed mediastinum. This is important again for another disease later on. So that's basically C. Then you look at D, which is the diaphragm, including this, which is the costophrenic margin. If I have fluid over here, what do I call this? If I have fluid right here, plural what? Effusion, okay? So if there's blunting of the costophrenic margin or white all over here, this is a sign of pleural effusion. Okay, so this is a normal chest X-ray. Now, in terms of the lungs, another additional findings, we'll mention it in the next slide. Let's look at the lungs. How many lobes are in the right lung? 3. How many lobes are in the left lung? 2. So when you do a lateral X-ray, for example, you can see, for example, this is going to be the right lung. You can see one lobe, which is a lower lobe, middle lobe, and then upper lobe of the lung. Okay, that's basically that. Additional information, for example, when we're looking at a chest X-ray, the way we report our findings is we divide the lungs into 3, like this, and we say upper zone, middle zone, lower zone. That's an additional thing that you want to know. Other than that, you need to identify the pathologies that you can see on a chest X-ray. Additionally is this. What is the difference between these two modalities? Or 2 different X-rays? What is the difference between them? Good. AP versus PA. Which one is PA, A or B? So the one that's PA is A. Okay. Y is the scapula. This. If you can see the scapula clearly, that means you're taking a picture basically from anterior to posterior. This is AP view. Okay. The scapula is going to come in the way of the picture, which is usually why we don't do AP. We want to visualize the lung tissue very well. So we do a PA view, which is image A. Can you see the scapula margins really well? No, not really. Okay, so that's why we do A, which is PA. Memorize these 2 images in case it comes as a trick OSPE question. Okay, this is PA. Can you see the scapula? Not really. Okay, this is why we go for this image, the modality or PA view. Now, in terms of the pathologies you can see on chest X-ray, it's basically these findings, okay? Plus minus a few other diseases, and we'll get into it in the miscellaneous parts. First of all, is if you have fluid in the lung, this is what we call consolidation. If a lung collapsed, this is what we call atelectasis. What is the difference between the two? In consolidation, it's basically fluid filling the alveoli, okay? Not the lungs collapsing, the fluid is filling the alveoli. So it's gonna follow either a lobar pattern, which is, for example, lobar pneumonia, or bronchopneumonia, which is gonna be like all over the place. The things that you can see with consolidation is something called silhouette sign and air bronchogram. What does air bronchogram mean? Is basically you can see the airways. They're still patent because it's not collapsed. The lung is still patent. It's just fluid in the alveoli. The rest of the airway is still there. So you can see these markings of the airway. Okay, and I'll explain it in the actual X-ray later. But you can see these airway, which is what we call air bronchogram. This you will not see in atelectasis because atelectasis is a collapse, completely collapsed lung. Okay, this is one sign of consolidation. The other sign is something called silhouette sign. Silhouette sign is basically if you have, for example, consolidation right over here. If there's consolidation right over here, you will not be able to distinguish the heart tissue with the actual consolidation with the lungs. This is what we call silhouette sign. And it's more, I'll show you an image later on. In atelectasis, none of these features are there. So you can still see the margin of the heart. That's number one. Number two, you won't see air bronchogram. Okay. And when patients with consolidation, they typically present with a picture of heart failure leading to a pulmonary edema or pneumonia. One of these two can cause it. That's consolidation. Next thing is interstitial markings. If you have a disease that either causes fluid in the airways, so for example, pulmonary hypertension, left heart failure causing pulmonary edema somewhat, and more importantly, thickness in the walls of the airways, such as an interstitial lung disease, you'll see these interstitial markings, okay? So interstitial markings, I want you to remember 2 causes. Number one, interstitial lung disease, and we'll see it. And number two, we explained it last time, is heart failure. Okay, the curly B lines and the interstitial markings. This is what we see with interstitial markings. Then we have nodule and mass. Do you guys know the magic number that differentiates these two from each other? Well, how much should it be, the size, for it to be a nodule versus a mass? 3. If it's less than 3 centimeters, it's a nodule. If it's more than 3 centimeters, it's a mass. That's the difference between them, okay? Just know it for the sake of basically the terminology if they put it in the exam, okay? Nodule 3, mass more than 3, okay? This is basically the chest X-ray pathologies. Going into actual images, if you have consolidation, this is not a very clear image. I'll show you in a bigger image and test you on it later. But basically, it's going to follow. This is more of a lobar consolidation in the upper right lobe of the lung. And you can see, for example, some airway markings. But again, it's not really that clear in this image since it's small. I'll show it later. Diffuse consolidation, if you have, for example, bronchopneumonia, or if you have, for example, atypical pneumonia, it'll show up like this, where it's diffused. Then you have atelectasis, which is basically a collapsed lung. This one is the right upper lobe of the lung. It's completely collapsed, or white out of the lung, okay? Then interstitial markings, which are basically these random lines you can see here. 1, 2, 3. This is most likely interstitial lung disease. Same thing with here. Then you have nodule, which is what I mentioned as less than 3 centimeters, and you can tell the difference. Basically, you could tell the difference between them if you do another imaging modality, and I'll explain which one later. Then lastly, multiple masses. What will cause multiple masses to show up in the lung? What will cause it? If you have multiple masses, it's metastasis. Someone asked in chat, what causes the lines? Which lines? In the interstitial? So interstitial, the lines itself, is because of either one of two things. Number one, increased thickness of the interstitial, okay, which is between the alveoli, between the airways. This is classical in what? Interstitial lung disease, because there is thickness of the walls, okay, increased thickness of the interstitial. The other one is in pulmonary edema because of backflow of blood into the interstitial. Same thing, okay? So this is interstitial markings. Remember these two findings. Pulmonary edema due to heart failure is one big cause, and interstitial lung disease, okay? We'll go over each of these images in more detail, but this is basics of radiology in pulmonary. Now, if you have a patient with a mass, nodule that you saw on chest X-ray, if you have a patient with COPD, interstitial lung disease, the next line you do after chest X-ray, if you haven't diagnosed it yet, is chest CT. Why is this better? It's because it gives you a 3D view, basically. Because if you see a nodule, for example, here, or a mass, you won't know where the mass is in the lung. Here, it will tell you where it is. Is this mediastinal mass? Is this a lung mass? Is this a chest wall mass? We don't know from an X-ray. CT, we can. This is a window that we call a lung window, which is basically we're putting the attenuation of the image of the X-ray, of the CT, to match the lung, which is going to be low attenuation because the lung only has air, okay, which is very low. So this is basically the lung window or lung attenuation. You can see all the, for example, the airways, you can see the, for example, the left and right bronchus and so on. The diseases I want you to remember here is, for example, classically, interstitial lung disease. You will get an image for interstitial lung disease on CT, okay? 100% you will get it. And then some other pathologies, and we'll get to it. So now we'll go over the diseases after we went over the basics of pulmo, basically. In COPD, it's basically divided into two main diseases, emphysema and chronic bronchitis. In COPD is basically an obstructive airway. It's basically causing the patient distress to exhale mostly, okay? And I'll explain the pathophysiology later. This is basically the gist of COPD. There's another disease that's asthma. What is the difference between asthma and the chronic obstructive pulmonary disease? Which one is reversible, asthma or COPD? Asthma. COPD, which is emphysema and chronic bronchitis, are not reversible. They are chronic injury due to, most commonly, smoking, okay? Which causes destruction of the airway or thickening of the airway, okay? One of these two. In asthma, it's reversible due to a specific finding, a specific etiology, a specific risk factor. So, for example, dust, okay? They go outside, for example, they inhale dust, they start getting symptoms of asthma. They go back inside, خلاص, it's gone. Or they use medications. This is asthma, okay? Now we'll start with the COPD and emphysema and chronic bronchitis. First of all is the pulmonary function tests. This is very important. Let's go over it one by one. First of all, the residual volume. In COPD, you have destruction of the alveolar walls, right? And destruction alveolar walls will cause more air to be trapped inside the lungs, okay? Because there's more space now for the lung to hold air. So what will happen to the residual volume? Increase or decrease? Think about it. Increase, good. How about the FRC, which is a functional residual capacity? It's the exhalation plus the residual volume, increase. Total lung capacity, increase. Now, the most important ones are these. Now, in emphysema, and then I'll talk about chronic bronchitis. In emphysema, you have destruction of the alveolar walls, right? This will cause disruption of one important physiological mechanism, which is elastic recoil of the alveoli. When you're inhaling, what will happen for exhalation is recoil. It will push the air out. In emphysema, because of smoking or other causes, this recoil is no longer there. So it will hold the air inside the lungs, which is why you guys mentioned correctly, these parameters will increase. Now, what will happen if the patient tries to exhale? They have to put additional force to release the air, okay? Additional effort to increase or push the air out to expire. If you really think about it, what will happen to the FEV1? Because they're now trying to force themselves the air out, but the air will stay inside. So will the volume be up? No. So it will decrease. Good. How about the FVC? Will it increase or decrease? Same thing. It won't be, they won't be able to release all the air from the lungs because they lost that recoil function. So that will also decrease. Which one will decrease more, FEV1 or FVC? FEV1. This is important, very important. So what will happen to the ratio? Decrease. And what was the number that I mentioned earlier? Less than 80 or less than 0.7, okay? Either two numbers. So that is basically the changes in COPD, and memorize these changes, okay? Is this clear for you guys why these parameters change? Okay. So in the flow volume loop, it's basically showing you the same pattern. The FEV1 will no longer be basically going up as much as before, so that's why it's decreasing, and the FVC is extended. They'll need more time to exhale everything because of the increased effort, and their ability to exhale is now less. And then this is basically showing you the obstructive pattern, as you can see here. Okay, so this is COPD. Now, you do chest x-ray for this patient who comes to you as a chronic cough, dry productive cough, or dry cough, sorry, not productive, dry cough for many months, is a chronic smoker, and has lost weight over a long time, and you can see them as pink and puffing air. What is their disease? Emphysema. the thing that I mentioned is pink puffers. I'll explain what that means. So on chest X-ray over here, you guys mentioned it's emphysema. Excellent. What are the features of emphysema on chest X-ray? This will 100% come. First of all is barrel chest. Excellent. So barrel chest, it will look like a barrel, and this is mostly in physical exam as well. It will look like a barrel. Okay. Next thing, as you guys mentioned, is the anterior-posterior diameter. This will increase. Okay. Or this entire thing. Then you have the retrosternal space, which will increase. I gave you this one. Now, what happened to the mediastinum? This entire mediastinum. Not widened, opposite. Compressed because of the air. Okay, narrowed. So that's what happened to the mediastinum. One more thing that I want you, or two more things. The spaces between the ribs, has it increased from the normal usual? Yes, okay. One more thing. What happened over here to the diaphragm? Flattened. Excellent, good. So flattened hemidiaphragm or flattened diaphragm, both of it is right. Okay, and this is basically showing you every single thing. Increase AP space, increase retrosternal space, the space between the ribs, radiolucency, basically it will appear more black because there's more air in the lungs, and you guys mentioned everything else. Okay, this image on 100% will come. Okay, either an MCQ, SAQ, or OSPE. One of them, it will come. All right, memorize this image and memorize the presentation of the patient. Usually it's a patient with a chronic dry cough for emphysema, typically a smoker, okay, chronic smoker. And this has been going on for a while, and they basically will puff air every time they try to exhale. Why is the oxygenation normal? Is because the alveoli, the interstitial space, is normal. So oxygenation happens normally. However, air will trap in the lungs, so they will be forcing themselves to exhale, which is why they are puffers, okay? They try to, basically, the characteristic sign they put in the scenarios is, for example, they're puckering out their lips every time they exhale. Okay, so that's basically emphysema. Now, what happens in emphysema? As you guys already mentioned, we obviously know this emphysema is destruction of the air, of the alveolar walls. Okay, so there's more space now. Now, what is the most common cause of emphysema? Smoking. Now, perfect. What if I show you, incidentally, we did a biopsy of the liver and it gave me this. What is the cause of emphysema? Alpha-1 antitrypsin deficiency. Good. What is shown in the liver? Accumulation of the alpha-1 antitrypsin. Pass positive. Excellent. Good. Basically, in alpha-1 antitrypsin deficiency, they have, basically, it's produced in the liver and then it goes to the lungs. In the liver, it accumulates. Okay, it accumulates. However, it's not going in the lungs. So that's why you have emphysema in the lungs. And in the liver, you might have increased liver function tests, for example, and cirrhosis later on, which is liver disease later on. So this is alpha-1 antitrypsin deficiency. There's multiple genes associated. Which one is associated with the worst alpha-1 antitrypsin deficiency? Or like genotype or whatever. ZZ, excellent. Good. PI is easy, excellent. So this is emphysema. Now, if you have a smoker, now you have multiple types of emphysema depending on involvement of the acini and the alveoli, right? If it's a smoker, what type of, exactly, panacinar, which is going to be involving the acini completely, the airway plus the alveoli. How about if it's alpha-1 antitrypsin? Centroacinar, good. How about if it's a patient with pneumothorax and bulla? Which one? Distal acinar, good. Memorize these, and you guys already mentioned it. If it's basically in the center of the acini, in the respiratory bronchiole, for example, it's gonna be because of alpha-1 antitrypsin usually. Panacinar is gonna involve both the ducts, the acini, and the alveoli, all of it. This is in This is in what's it called? In smoking. Okay. Correct me if I'm wrong. Is it the opposite? Okay. The opposite. Sentry is smoking. Good. And then pan-acinar is with the alpha-1 antitrypsin. And if you really think about it, smoking will come here first. It will affect this area. And then alpha-1 antitrypsin, the entire thing is damaged. So you have pan-acinar, if you really want to think about it that way. Distal, exactly, smoke goes up. Distal is in the case of bulla that forms, which bulla will mostly form here distally. Okay. And when the bulla rupture, it will cause a pneumothorax. Okay. So this is distal acina. This is basically the emphysema types. In terms of pathogenesis, it's simple. Two factors that we have involved. Either more elastases, which is the inflammation, or decrease alpha-1 antitrypsin. One of these, okay? Smoking will cause a functional decrease in alpha-1 antitrypsin and will increase elastases, which will cause the tissue damage, okay? In alpha-1 antitrypsin, this won't be able to neutralize the elastases, so the elastases will cause tissue damage. That's basically it, okay? This is the pathogenesis, very simple. You have elastases as the main mediator of the damage to the alveoli. It's mostly protected, or let's just say neutralized by the alpha-1 antitrypsin, but this isn't there, for example, because of the smoking or because of congenital deficiency. All right, so this is emphysema. Now, you have this patient comes to you with, let's just say, 6 months of repetitive productive cough, and it's been going on for more than 4 years. What is this diagnosis? Chronic bronchitis. Good. What is the cause of chronic bronchitis? Most common cause? Smoking. How do you want to diagnose it? What in the case that I mentioned gave you the diagnosis? Exactly. 3 months of productive cough for at least 2 years. Good. And it's usually a productive cough. Why? Is because the smoke itself will cause more glands to form. Okay. Now, with more glands, it will become, the cough itself become more productive because there's more mucin. Now, if you look at this pathology, what is the finding that we can see here is there's increased number of glands, okay? This is the main thing. Now, there is an index that we follow. I think it's called the Reed index, which is basically the proportion of the glands to the epithelium, smooth muscle, and the cartilage. If it's more than 50%, I think, this is basically diagnostic of chronic bronchitis. However, you diagnose it based on 3 months of cough for at least 2 years. That's it. Okay, you will see this in the case. 3 months, 2 years, done. Okay, this is chronic bronchitis. What is chronic bronchitis caused by? Smoking, most common thing. Now, typically also, they are described to be blue bloaters, okay? That's another finding. So they will be slightly cyanotic because they hold the CO2 inside. They won't be able to exhale the CO2 properly, okay? So that's basically blue bloaters, chronic bronchitis, okay? Now, moving away from COPD is asthma, okay? Asthma, as we said, the difference between them is asthma is reversible. COPD is not. Now, for asthma itself, the main pathogenic point of asthma is there is an allergen, okay? There's something causing the symptoms. The allergen could be dust, could be, for example, certain pets, for example, the hair, could be pollen, this is more common in the West, and some other stuff, okay? This reaction will cause basically inflammatory reaction and bronchoconstriction. What happens actually is this allergen, firstly, you have the antigen presenting cell, which is a dendritic cell. It goes, gives it to a naive T cell that then basically turns into a T helper 2 cell. This T helper 2 cell secretes 2 cytokines. That's important. IL-4 and IL-5. IL-4 will cause class change from IgM to IgE. Okay? IgM to IgE. And this is going to be basically a plasma cell secreting IgE by interleukin-4. IL-5 will cause eosinophil recruitment. Why is it important to remember which one causes? It's because you can block IL-5. In certain medications can block that one. Now, what will basically IgE do? It will basically bind to mast cell. Now, when you have a second exposure of the antigen, of the allergen, it will basically directly bind to the IgE and cause this mast cell to release its granules, which has what? Serotonin, and more commonly, very importantly, histamine. Okay? So these granules and mediators get released. Chronically, you have inflammatory markers that gets released, or inflammatory cytokines that gets released, and you have, for example, leukotrienes and so on, that basically causes bronchoconstriction, okay? And increased wall thickening and mucus production. So this is basically that. Why is this important for us to remember all of this? Is earlier on it's bronchoconstriction, later on it's inflammation, is management, okay? If you want to acutely manage asthma, you control bronchoconstriction. If you want to chronically manage asthma, you block inflammation. That's basically that, okay? And I'll go over the medications. Another thing is you have increased amount of mucus, and pathologically, if you do, for example, if you take a mucus sample and you look at it under pathology, you can see two findings in the mucus. First one is called Charcot-Leyton crystals. The other one is Churchman spirals. They might write it for you in the case itself with a pathology question. If it comes up, you know the answer now. Charcot-Leyton crystals and Churchman spirals, okay, for asthma. But this is basically the pathogenesis. Now, when you're trying to diagnose asthma, firstly, from the history itself, you can kind of guess it's a young patient or whatever, goes outside, gets symptoms, or they're running and it gets worse. That's number one. Number two, you basically identify the exposure points. So whether it's, for example, if a guy telling you, I'm going out and when it's dusty, it gets worse, avoid dust. And then if it gets better, you most likely know it's asthma. But what is one test that you do for asthma patients to diagnose them? One important test that you do, other than clinical diagnosis. The same ones we mentioned for COPD. Spirometer, pulmonary function test. And excellent. You mentioned. You basically check the pulmonary function test, the spirometer. You check the FEV1 and FVC. Initially, when the first time you do it, it will become an obstructive pattern because that's literally what's happening with asthma patients. But you give them a bronchodilator, and what happens? It improves, okay? It resolves. So you can see the FEV1 is low in this case before the bronchodilator is given, and then afterwards it improves. The magic number, I don't think you guys need to know, but in case, it's 12%. If there's a 12% increase in FEV1 post or after bronchodilator, this is a diagnosis of asthma, characteristic. Now, if you cannot do this test for some reason, what is another test you can do? Similar to a, spirometry, but what else can you do for this patient? This is rarely done, but you can do something called the opposite of this. Methylcholine challenge test, okay? What is methylcholine challenge test? It's basically this one, you're giving them a bronchodilator. In methylcholine challenge test, you're giving them a bronchoconstrictor. And you're seeing exactly, muscarinic agonist. Excellent. So muscarinic agonist will cause constriction. So in this case, the FEV1 will decrease. How much it decreases by gives you the severity of asthma, okay? But again, this is rarely done. This is always done with asthma, okay? So memorize bronchodilator test, all right? Now, as I mentioned, for the case of yes, you owe it, clinically, usually you firstly take history and physical for the patient, obviously. Then for diagnosis of asthma, it's either clinical or you do a spirometry, okay, or both. Okay, obviously clinicals from history and physical, but then you order a pulmonary function test and you see reversibility for asthma. Okay, so yes, you do spirometry. Methylcholine is not done because if you really think about it, you're gonna put the patient at risk. So you don't want to do that. Okay, so that's basically the diagnosis of asthma. Now for management, it's acute management, long-term, and targeted therapy if these two failed. Number one is acute management by simple bronchodilators. Okay. Now you have two main receptors. You have the beta receptors, beta 2, and muscarinic receptors, right? If you have activation of beta receptors, do you have bronchodilation or constriction? Bronchodilation. How about muscarinic? If you have activation muscarinic, constriction. Excellent. Now, when you activate beta 2 receptors, it causes increase in cyclic AMP, right? What will break down the cyclic AMP? What enzyme? Phosphodiesterase. Excellent. The main goal is you want to increase cyclic AMP. So you do that by either beta 2 agonists, okay, or methylxanthines, which are phosphodiesterase inhibitors. Cool. This is basically that. And you inhibit muscarinics because that will cause dilation. So this is bronchodilators. Long-term control controls what? Does it control bronchoconstriction dilation or inflammation? Which one? Typically, inflammation. Plus minus, you have long-acting, which will basically keep it bronchodilated, but ignore that. We want to affect inflammation. The best drug from all of these is corticosteroids. Okay, inhaled corticosteroids. The main actual say of management of asthma, what we do for every patient is we give them the first line therapy is inhaled corticosteroids plus SABA, which is short-acting beta agonists. This is mainstay. You give them the inhaled corticosteroid, and whenever needed, take this. This is the current management. If it does not work, then you give them a long-acting, and if that doesn't work, then you can give oral corticosteroid, which is rarely done, but if for severe asthma, maybe. Then you add one of these drugs, okay? These drugs also inhibit either the mast cell from releasing histamine, so these are mast cell stabilizers, it keeps it from degranulating, or you inhibit leukotriene. You either inhibit the leukotriene receptor or the enzyme that converts, what's it called? That converts from the cyclooxygenase pathway into leukotriene, okay? These are the two methods. If all of these didn't work or a patient for some reason cannot take any of these drugs, then you can go for these targeted therapies. Let's mention them. So firstly, as I said, acute response, you do all of this, and you guys already mentioned everything. And same thing. From arachidonic acid, you have lipoxygenase, which will convert it to leukotrienes, okay? Leukotrienes, you either inhibit this enzyme, okay, by xylutin and whatever, or you block the receptor for leukotrienes, which is, for example, with montelukast or zafirlukast, okay? Then from there also, you have, if you want to have targeted therapy, you either inhibit interleukin 5 for eosinophils or IgE. Let's take these drugs one by one. So first of all is beta-2 agonists, and you have albuterol, salmeterol, salbutamol, formoterol, whatever. They basically will acutely relax the bronchial smooth muscles, which will cause bronchodilation, which will improve patient asthma attacks. Albuterol is usually short-acting, salmeterol is long-acting, and formoterol, salbutamol is also another short-acting one. Now, in the cases of, for example, anaphylaxis, where they have severe bronchoconstriction, you want something that's rapidly acting. And anaphylaxis as well, exactly, excellent. And anaphylaxis as well, they have hypotension and shock. So you want to give epinephrine, which is non-selective because it has alpha and beta, okay? So that's basically for beta-2 agonists. Epinephrine is usually given for anaphylaxis. Never give it for asthma, okay? Then you have the inhaled or oral glucocorticoids, which is usually fluticasone or budesonide. Now, for corticosteroids, it's very important for you to do certain things. Now, inhaled corticosteroids, what's the common side effect from inhaled corticosteroids? Inhaled. What can happen in their mouth? Oral thrush, candidiasis. Excellent. Candidiasis, oral thrush. Your mouth after use. This is very high yield. Okay? Very high yield. Then you have, let me go to methylxanthines for acute. And methylxanthines, you basically want to cause bronchodilation by inhibiting phosphodiesterase, which will increase cyclic AMP. Okay, here's some side effects: cardiotoxicity, neurotoxicity, metabolized by cytochrome, so it interferes with other drugs. Okay, but this is basically theophylline methylxanthines. Is this usually given clinically? I have never seen it. Okay, from my last 2 years. Okay, it's usually the other drugs that I mentioned. Now, lastly is muscarinic antagonists, which is basically ipratropium or whatever. They block muscarinic receptors, bronchodilation. Okay. Now, very importantly for the muscarinic antagonists is the usage in COPD. These are the drugs that we give for COPD. Okay. Remember, muscarinic antagonists usually used for COPD. Okay. If these didn't work, we add on other medications such as anti-leukotrienes, montelukast, zafirlukast, which will block the leukotriene receptor. A specific indication and basically efficacy of it is for aspirin-induced asthma. They're taking NSAIDs, okay? And this will produce asthma symptoms for some patients, or exercise-induced asthma. This is a specific indication for them. Or xylutine, which is a 5-lipoxygenase inhibitor, again, in basically decreasing leukotrienes. Now, another one is basically chromalin, which is a mast cell stabilizer. It prevents degranulation. Okay, again, rarely use these medications. Only if it's very severe, you add on. Okay. Now, going into the targeted therapy, you have anti-IgE, which is omalizumab, which binds to IgE. Very simple. Again, this is very rarely used because number one, monoclonal antibodies, clinically, it's expensive, okay, to give to the patients. So usually you never give it. Same thing with IL-5 monoclonal antibodies, such as these. Again, never usually give. Okay, this is basically asthma management and pathogenesis, diagnosis, everything. Now we go, sure, we're almost done with this section. Now we go into this disease. What's happening here? Bronchiectasis. How do these patients present? Usually it's a patient with some underlying disease, I'll mention it, coming to you with repetitive infections. That's number one. Number two is their cough. It's very productive sputum and smelly sputum. Okay, this is typically the presentation. Now, bronchiectasis is dilation of the airways, okay, of the proximal airways, major big airways, and you can see this ring sign on a CT. Now, for bronchiectasis, it's very important for you to remember the causes. Already, mashallah, you already mentioned one of them, cystic fibrosis, and one of the most common causes. So in cystic fibrosis, you have repeated infection because there's mucus buildup. Bacteria love this. You go and it causes repeated infection. This repeated infection can cause cystic fibrosis. What is the organism typically that causes repeated infection, cystic fibrosis? Typical organism. Pseudomonas. Excellent. I'll cover this in micro. But that's basically that. Other causes of bronchiectasis, you have classically something called Carter-Jenner syndrome, exactly, which is also called primary ciliary dyskinesia. The cilia can't move anymore, so mucus can't move. Mucus stays, bacteria love. That's it. Repeated infection. So that's basically bronchiectasis. Now, how about this? You have a patient, chronic smoker, presents you with long-term coughing. You do a CT and you see this. Interstitial lung disease. What do you see on CT? Give me two findings. Fibrosis or interstitial markings and honeycomb pattern. This image, I think, or no, sorry, this image most likely will come. This one or this one. The honeycombing, if you'll ever look at a honeycomb, it will just basically be these circles and then with space in between. Basically what's happening here, okay? This is a honeycomb pattern. Another thing is interstitial markings, as we said, for ILD, okay? So interstitial markings such as you can see here, okay? All of these markings. ILD. This will 100% come in the exam. Okay, this is a chronic ILD, most commonly caused by smoking. However, you do have something called, which is idiopathic pulmonary fibrosis, which is a separate entity. And then you have environmental causes for ILD, which we'll get to all of these environmental causes. Importantly is what's happening in ILD. What's happening in ILD is because of the smoking or because of the environmental factors or something, the thickness in the interstitium between the alveoli is thickening. Okay, it's becoming thick. When it becomes thick, this is going to affect oxygenation. That's number one. So the patient will have a decreased diffusion, which will cause decrease in oxygen. Okay, so there's a specific test you can do for this, which is called DLCO, which you're basically looking at carbon monoxide diffusion, and they will have DLCO, which is diffusion limitation carbon monoxide. They won't be able to diffuse it properly because of the thickness of the interstitium. Because of this thickness, the amount of air in the lungs will decrease. So what will happen to all of three of these? Decrease, okay? They won't be able to hold the lung, the volume as much. The compliance will decrease. Now, how about FEV1 and FVC? Is there an issue with expiration? Typically, not really. So what will happen to these? Or just tell me the change in the ratio. Normal or slight increase, okay? Exactly. These both parameters will decrease. It's not like emphysema where you can identify that their issue is with expiration, with releasing the air. Here, it's a bit because the lung itself is fibrous, it's thickened. So it will both be decreased proportionally. Okay, not like in emphysema where this is markedly reduced. So remember this value for FEV1 FVC ratio could be normal, so 0.7 or 0.8, or increase of 0.9. Okay, remember this. And everything else, lung compliance will be decrease. That's ILD. Flow volume loop, just remember it because it's supposed to be up to here, the total lung capacity, not here. It's less. And it looks the same. It's just less because fibrous lung. That's ILD. What about this patient? You took history from them. Could be a smoker, but there's no environmental factors, no exposure, idiopathic pulmonary fibrosis. Okay, that's one of the most common causes of interstitial lung disease or restrictive lung disease. In chest X-ray, clear picture of interstitial lung disease, you can see interstitial markings. Okay, which is again because of the thickening. Now, we'll go over the environmental causes, which are called pneumoconiosis. In this patient, what type of pneumoconiosis is causing the interstitial lung disease? Co-workers pneumoconiosis. Why? As look at just the color of the thickness. This is all thickened. This is the normal alveoli, this one. This is the normal interstitial. This is much more thickened and it's colored black. Good. This is co-workers pneumoconiosis. Typically in minors, because cold. Very importantly, do these patients have a risk of developing lung cancer? Yes or no? No. Remember this. No, no, no. Okay, they will not, they don't have risk of developing lung cancer. Okay. How about this? What type of pneumoconiosis? Silicosis. Now, silicosis What basically demographic of patients, or what are their occupations typically? Give me two. Sandblasters or miners, good. Now for silicosis, you can see here a silica nodule. This is a normal, not normal, but the other part of the lung, and this is one big silica nodule. And you can see some bifringes or some like color basically to it, because these are the silica nodules itself, or the silica itself. Now, for silicosis, do they have a chance or a risk of developing lung cancer? Yes. What other infectious disease do they have a risk for developing? TB. Do you guys know why they have a risk of TB? Why? They inhibit the phagolysosome formation. Good. Okay. This will basically not, you won't be able to control TB anymore because of the whole macrophage phagolysosome thing. So you'll have TB infection. Silicosis, risk of TB and lung cancer. Co-workers pneumoconiosis won't have a risk of lung cancer. Remember this. Okay, silicosis. How about in this patient? I'll tell you, they were a plumber. They worked as a plumber. 50 years later, came with this. All right, let's take it one step back. Asbestosis, excellent. Mesothelioma, we'll go over how that happens. So this is asbestosis. And asbestosis, you have pleural thickening, okay? But it's not malignant yet. So this is asbestosis. If it's malignancy, mesothelioma. With an incidental finding of this, what's happening with them? This is pleural effusion with it, okay? So this is pleural effusion with the incidental finding of asbestosis or pleural thickening. Good. Characteristically, it's described as a plumber who developed this, okay? Or what's it called? A shipwright, okay? Worker. I usually see either one of these in question stems, okay? Shipwright, or the ones that work in the docks, for example, or plumbers, all right? So this is asbestosis. What do you see here? Same patient who's a plumber, asbestosis, okay? What do you find here? What is this? Which is what we call ferruginous bodies or asbestos bodies. Excellent, good. Okay, good. This is ferruginous bodies, or however we pronounce it, which is asbestos bodies. Here you can see pleural thickening, all right, with some fibrosis that's happening in this part of the lung, okay, because of all the white spaces. Here you can see there's less white spaces. Here there's more, which just means that there's interstitial lung disease, okay, with asbestosis. Now, you have a patient, a female, 40 years old, 30 to 40 years old, presenting to you with signs of interstitial lung disease with hypercalcemia. You do an X-ray and you can see this. What do they have? Hilar lymphadenopathy, bilateral hilar lymphadenopathy, which is what disease? No, no. Sarcoidosis. Yes. Please remember this presentation. A female patient, typically, even if you want to go even more detail, it's usually described as an African American female, okay? Around 30 to 40 years old, this is the range. Presenting to you with signs of ILD, so they might have a picture of interstitial lung disease, cough, and whatnot. And they will always provide you with this finding of bilateral hilar lymphadenopathy. Characteristic of sarcoidosis. Sarcoidosis until proven otherwise. Okay. Other lab findings you might see is hypercalcemia. The reason why you don't need to know, but just to explain, just so you can picture it, is in sarcoidosis, basically the cells, the macrophages typically, will have intrinsic activation of vitamin D. When vitamin D goes around, it causes high calcium. That's basically why they have hypercalcemia. Remember, female, usually in the 30 to 40 range, ILD picture, bilateral hilar lymphadenopathy, sarcoidosis. Okay? Good. Yes, they have hypertension as well because they have intrinsic ACE enzyme. Okay, so they might have hypertension. Good. Now, what do you see here? Very important. Non-caseating granuloma, which goes with sarcoidosis. If you have caseating granuloma in the lung, what's the disease? TB. Non-caseating sarcoidosis. Then you have what's it called? The Shaman bodies and asteroid bodies. Here you can see some calcification in it and whatnot, which is basically a group of macrophages. Okay, so this is sarcoidosis. Remember these two images because it might come in the OSPE. But this image, very high yield to remember, is it's a non-caseating granuloma sarcoidosis. Now, you have a patient who has these findings on pathology before I give you a scenario. Can you guess just based on these images? Okay, good. Pulmonary hypertension. Good. So pulmonary hypertension is basically defined as elevated pulmonary blood pressure. What's the cutoff number? Usually the number is 10 to 15, the normal. What's the number that defines pulmonary hypertension? 25. 25. Above 25 millimeters of mercury. Okay? So this is pulmonary hypertension. Now, pulmonary hypertension, just think of systemic hypertension, but in the lungs. Okay? So what do you see here? Medial hypertrophy. Remember I showed you arterial sclerosis before? Similar thing that can happen in the lungs. Because of the medial hypertrophy that's happening in pulmonary hypertension, there is increased angiogenic factors because this part of the lung is not getting the good supply anymore. So it releases VEGF and whatnot, and it forms this. What do we see here? Plexiform lesions, which is blood vessels. Okay, why is because of this. So this is pulmonary hypertension. Now, importantly for you guys is you need to identify the types of pulmonary hypertension. There's 5. Type 1 pulmonary hypertension is usually caused by what? Idiopathic. Excellent. What is the gene mutated or implicated? BMPR2. Excellent. Perfect. BMPR2. Usually it's a female patient. Okay. Pulmonary hypertension has no other signs that may be the underlying reason for pulmonary hypertension. Idiopathic pulmonary hypertension, BMPR2 mutation. Okay. What about type 2? What is it usually caused by? Heart diseases. Excellent. Which is left heart failure. Okay. Pulmonary edema, this backup of blood will cause increased pressure, pulmonary hypertension. So that's type 2. How do you manage type 2? It's easy, is you manage the heart failure. Type 3, pulmonary diseases such as what? Very common. We covered it, COPD, good. Type 4, sorry. Embolism, okay, PE. Type 5. What is type 5? Everything else, okay, others, good. Perfect. So you guys already mentioned this. Ignore first aid value. Memorize 25 because it was in your slides. And just memorize in group 1 or type 1, it's BMPR2 gene, usually in females, it's idiopathic. Now, in this category of patients, the defect is increase in vasoconstrictors and decrease in vasodilators. How do you have vasoconstriction? Endothelin. So how do you want to manage these patients? Give them endothelin blockers. Done. And you have decrease in vasodilators. How do you want to vasodilate? You either give phosphodiesterase inhibitors or you give prostacyclin. Phosphodiesterase inhibitors will increase nitric oxide. Cool? That's basically the management. We'll go over the specific drugs. Ignore this. And you guys already mentioned these. What do you do for these patients to control pulmonary hypertension? Treat the underlying cause. If it's heart failure, treat heart failure. We mentioned that last time. COPD, we mentioned how to manage it slightly. All you need to remember is for COPD management is you give them muscarinic antagonists and basically pulmonary rehabilitation. Okay, it's similar to physical therapy, but for breathing. Okay. Another thing is you can give them as oxygenation. You have to give them antibiotics because they usually get infections. Honestly, this is out of your scope. So just memorize how to diagnose COPD. Management is, if you want to use a drug, antimuscarinics. Then you have thromboembolic, which is basically PE. Okay. And this is multifactorial, other stuff. So this is pulmonary hypertension. Treatment, you block endothelin 1 receptor, such as with drugs called Boson 10. And this drug is hepatotoxic, so you monitor LFTs. Done. Next one is you inhibit phosphodiesterase, you increase nitric oxide. The classical drug is sildenafil. Sildenafil, what's the actual use clinically for sildenafil? Erectile dysfunction. The drug, what is this drug? Viagra. Okay, this is basically that. Prostacyclin, another vasodilation, such as iloprost. An adverse effect is, for example, flushing and jaw pain. But for these drugs, just memorize the mechanisms. And then, for example, for this drug, it's hepatotoxic. So just memorize that. And that's pretty much it for pulmonary hypertension. These are less high yield than any other pharma lectures, okay? That's basically done with COPD, ILD, asthma. We're going to take a short break for prayer, as someone requested, and we'll come back in around, let's come back at 8:30, okay? And we're going to finish the next sections very fast. So, okay. So before I go into infectious for this next part of this crash course, I had a question I wanted to ask you guys. For interstitial lung disease, are there medications we can give for antifibrotic agents? Do you guys know any? طيب. In interstitial lung diseases, I highly recommend you know these two drugs. There are two antifibrotic drugs that we can give. Number one, and the most important one, is nintedanib. Okay. The number two is pirfenidone. Okay. I might have mispronounced it. It's in the clinical slides. If he asks you anything, it's that. Okay. Nintedanib and pirfenidone. Okay. That's the one thing I forgot to ask you guys. I mentioned it, but it's very high yield for you guys to know. Now, in infectious causes, typically we have upper respiratory tract infection, lower respiratory tract infection, TB. That's it. So for upper respiratory tract infection, you have rhinitis or pharyngitis. Ignore these two. For rhinitis, it's usually basically what we call the common cold or whatever. It's caused by rhinovirus, adenovirus, coronavirus, whatever. Okay, we'll go over the basic causes of these. Now, pharyngitis, usually either viral by influenza is a very common one I want you to remember, or these bacteria. Now, there's many bacteria that causes these. We'll go over them. Okay. So now, you have a patient with upper respiratory tract infection, pharyngitis, and it's a bacterial cause. What bacteria is causing this upper respiratory tract infection? Strep pyogenes, good. Okay. Now, strep pyogenes is basically diagnosed. What's the first line modality for diagnosing of strep pyogenes? Rapid antigen test, good. The second method is what? Culture. Usually would always have to do culture, but one second. Okay. So usually you don't really have to always do culture unless the rapid strep test is negative or inconclusive. Later on in your clinical years, you actually need to know how to differentiate the two. Okay. Usually first line is what I want you to remember. First line, rapid test. Gold standard, culture. Okay. Now for non-exudative diseases, okay, for strep pyogenes is basically the complications of strep pyogenes infection, which is one of two things, glomerulonephritis or rheumatic fever. Now, to diagnose either of these two, I mentioned it. What lab value will you want to order? What is it? Anti-streptolysin O, okay? ASO, antibodies. You want to order that. This is for non-exudative disease, which means not pharyngitis, not cellulitis, none of these. You want to diagnose rheumatic fever or post-strep glomerulonephritis, PSGN, you do it by anti-streptolysin O antibodies, okay? But this is strep pyogenes, good. How about this? A child is presenting to you with pharyngitis and you do physical examination, you see this Corynebacterium diphtheria, good. What do you see here? What do we call these? Pseudomembranes, good. They are gram-negative rods and gram-positive rods, and basically they are described as V-shaped or L-shaped organisms. That's number one, or clubs-shaped as well. Now for Corynebacterium diphtheria, what's very important for you to know is, do they produce a toxin? Yes or no? What does this toxin do? It's an AB toxin, and basically the mechanism is it inhibits protein synthesis through ATP ribosylation of elongation factor 2. That's the mechanism. This is diphtheria. Now, how do you differentiate toxigenic strains versus non-toxigenic strains? What's the test you do? ELEX test, good. ELEX test will check for the diphtheria toxin, which is the most important clinically thing that we need to look out for. Do they produce a toxin, yes or no? So that's diphtheria. Now, very important about diphtheria is, what is the complication of diphtheria? Other than blockage of airways, which could happen because of the pseudomembranes, but cardiomyopathy, myocarditis. This is the most important cause of death, okay, for patients with diphtheria. Other than that, it can cause neuropathy, I believe, and some other stuff, okay? But cardiomyopathy, myocarditis is what I want you to remember. Diphtheria, pseudomembranes, it has the AB toxin or exotoxin, which inhibits protein synthesis through elongation factor 2, and an ELEX test to diagnose it. And lastly, myocarditis as a complication, okay? So that's basically that. Now, other than that, you have influenza as a very common viral cause. It's an orthomyxovirus, which are enveloped negative sense single-stranded RNA viruses. Now, very importantly is two virulence factors that they have, hemagglutinin and neuraminidase. Hemagglutinin will allow the virus to go inside the cell. For the virions to be released, it's neuraminidase, okay? This is just an important thing for you to remember, because if they ask you questions about influenza, most likely it's the virulence factors, which are these two, okay? Now, for patients with upper respiratory tract infection with influenza, they're typically self-limited, which basically means that they will recover on their own. However, a very feared complication is bacterial superinfection that may happen, okay? Usually it's supportive therapy. Now, for influenza, they have a vaccine, which is something good, and also diphtheria as well. We didn't mention it, but diphtheria has one as well. But influenza has a vaccine, which is usually a killed or live attenuated vaccine, okay? The usual flu shot, there is a whole thing about it, which is egg allergy. Just remember that about the egg allergy. It can interfere with influenza vaccine. Clinically, not important, okay? Like in practice, it's actually like rebuked. They don't even look into that anymore. Now for the live attenuated vaccine, it's given intranasally, okay? So in the nose. That's anyways. Now, two phenomena that can happen in influenza is something called genetic drift or genetic shift, okay? The difference between them is, in genetic drift is some mutations that happens in the two variance factors I mentioned, hemagglutinin or neuraminidase. This causes a minor change. This is what causes minor changes in influenza every year. Okay, that's why every year we need to get a new vaccine because there's a change. There's a shift that happens every year. Now, for genetic shift, it's very different. Here, you have something basically called reassortment of the RNA, which is basically if you have two viruses, A and B, they get mixed up and basically they mix their RNA together. Okay? This whole mechanism, don't worry about it, but just remember that if you have genetic shift, you have more major outbreaks or pandemics. Okay? This is basically everything you need to know for influenza. Now, for management of upper respiratory tract infection, main important thing that I want you to remember is usually it's symptomatic supportive therapy. Usually, okay? Rarely we want to give antibiotics. We only give antibiotics in the case of bacterial infection. Okay, we give them because, for example, if that's Strep pyogenes, is cyanobacteria, they will have major complications that can happen. So we want to treat them with antibiotics. However, most of the time, we never give them antibiotics for normal upper respiratory tract infections. Why? It's mostly viral. Viral is self-limited. Number one thing we do for patients with upper respiratory tract infection, rest and hydration. Give them fluids, either by oral rehydration therapy or IV fluid if they're very dehydrated, okay? Then if they're feeling, for example, they have a fever or whatnot, we give them antipyretics, which is most commonly acetaminophen, Panadol, or NSAIDs. Now, for cough suppression, we have two things. Either we stop the cough itself, two drugs we can give here, and the expectorants, which is basically mucolytic agents. Okay. Now, for cough, antitussive medications, they basically are opioid inhibitors, okay, or opioid medications, or derivatives of it. You have number one, which is called dextromethorphan, which binds to sigma receptors. Memorize this. And we have number two is codeine. Okay, these are the two antitussives. Now, antitussives, I want you to remember, do we give antitussives to patients with asthma? Yes or no? No. Why? Why do we not give it? Causes, more importantly, is respiratory depression. Okay? We do not give antitussives, which basically blocks the cough in asthma because it might cause depression, the respiratory depression or collapse. Now, for expectorants, these basically are mucolytic agents. They break down the mucus. Now, I think this is what we call Robitussin. Okay. Now, in your slides, it's very dark green slides for Dr. Dana. There's two types, AC and DM or something. Memorize what medications are given with Robitussin, AC, and DM. Just memorize that slide. Most likely will come. So these are expectorants. Expectorants, when do we usually give them? In elderly patients and I think children as well. Nasal decongestions, if they have, for example, rhinitis or whatnot, what class of medications we give? Alpha agonists, okay? Such as phenylephrine, pseudoephedrine, stuff like that. An important thing about nasal decongestants is, do we give them more than 3 days? Very good. No. No, because it causes rebound congestion. Good. Now you have antihistamine, chromalin, which we talk about, and ipratropium and whatnot. These are the most important things you need to remember. Now, if they do have a bacterial agent that causes the pharyngitis, we need to give them antibiotics. Which antibiotics do we typically give? What's the first antibiotic you want to give? Penicillin, which one? Most common one, Augmentin, amoxiclav, good. What other medication do you want to give? From the beta-lactams. Cephalosporin, okay? You can give cephalosporin. Good. Augmentin, first line, usually, always. Patient bacterial, upper respiratory tract infection, Augmentin, okay? Other than that, we have cephalosporins. Now we'll go into lower respiratory tract infection. Lower, you have multiple things. First of all is if it involves the trachea, we call it tracheitis, which is usually caused by Staph aureus, or even strep pyogenes can cause it or something. Or strep pneumo, but usually it's Staph aureus. Then you have bronchitis or bronchiolitis. Bronchitis, we talked about chronic bronchitis, so ignore that. Bronchiolitis is usually a disease in children, and it's usually caused by a virus. Which virus causes bronchiolitis? Do you guys know? Yes, good. RSV, respiratory syncytial virus. Good. Bronchiolitis, typically in children, and it's caused by RSV. Now in the lung, pneumonia. Okay, and complications of pneumonia is abscess, one of them. Okay, pneumonia has many of these, and we'll talk about every single one of them. Now, for pneumonia, we have many different ways we can basically classify pneumonia. We have something called community-acquired pneumonia. We have something called hospital-acquired pneumonia. Community-acquired pneumonia, what is the most common organism? Strep pneumo. Good. For hospital, it's other things such as Pseudomonas, Klebsiella pneumonia, some other stuff. Okay? Other stuff. Another way we can differentiate pneumonia is by pathology. Lobar versus bronchopneumonia, or typical based on what organism causes it versus atypical bacteria. We'll talk about atypical bacteria here in details because I don't have slides for it. So the atypical bacteria, you have Legionella, Mycoplasma, and Chlamydia. Now, for Legionella, what usual source does Legionella come from? ACs, water sources, okay? Water sources, air conditioners. Usually, it's either in a setting that multiple people are living together, and most important is nursing homes. Usually, that's number one, they describe it. Number three, I think it's cruise ships as well can have Legionella. But anyways, now that's basically Legionella. Legionella needs two things to grow, I think cysteine and iron, and it grows on charcoal agar or something, charcoal yeast agar. Anyways, and it grows in specific temperature. Memorize, I think it's up to 40 degrees Celsius. Memorize the temperature. And another thing is clinically, these patients with Legionella, and they will write this in the scenario, will present with hyponatremia. Okay? Hyponatremia, low sodium. This is a characteristic feature of Legionella. This is a very important feature of it. Again, the source of Legionella is super important. Okay, air conditioners, water sources, coolants, that is the source of Legionella. Usually would affect elderly, and it causes atypical pneumonia, which is basically walking pneumonia. Okay, the patient doesn't have that many symptoms. But when you do a chest x-ray, diffuse consolidation. Okay, so that's basically Legionella, hyponatremia. Now for Mycoplasma pneumonia, it's a intracellular organism. Mycoplasma pneumonia typically causes atypical pneumonia, which is interstitial pneumonia, which is walking pneumonia, and it usually affects young people. So adolescents, teenagers, typically, and college students is the main demographic that they will put in a case. Multiple people living together, for example, in dorms, college students, Mycoplasma pneumonia until proven otherwise. Okay? That's Mycoplasma. Next is chlamydia pneumonia, or chlamydia pneumophilia. Chlamydia pneumonia is another facultative intracellular organism. It has an external and internal form of it. We have the elementary body and the reticular body. Elementary is outside, reticular is inside. That's chlamydia. Okay. Lastly, we have COVID-19 as another one of these causes. What I want you to remember from COVID-19 for viral causes of atypical or for pneumonia is the virulence factors, the surface and like the markers. Go over those slides just for those surface markers, because if they ask you anything, it's those. Okay, which virulence factor does it use to bind? Which it's that type of questions. Okay, that's basically that. Now, for bacterial causes, more importantly, is I want you to remember the factors for the bacterial pneumonia. Number one is alcoholism. The most common cause is Klebsiella pneumonia. Why is that so? Is aspiration pneumonia. They basically, because of alcoholism, they have a tendency to cause aspiration pneumonia, which is caused by Klebsiella pneumonia. How will this pneumonia feature? Feature as what is a sputum? We'll get to it later. Ignore this. Now for COPD, smoking, Haemophilus influenza is one. As I mentioned, cystic fibrosis, Pseudomonas is the most common cause. If you have a patient with repetitive infection, they are young, they might have pancreatitis, it's cystic fibrosis. Wool, bacillus, ignore that. Now, if they have influenza, as I said, they might have superinfection, bacterial superinfection, which is basically caused by Staph aureus. Ignore this, ignore this. Sheep exposure, Coxiella. Don't think you'll get tested on any of these, and Legionella is water sources. Okay. The most important thing, alcoholism, for example, cystic fibrosis and water sources in Legionella. The rest, I doubt will come because they're very low yield for your level currently. Yeah, this is basically that. Now, as I said, another way we can differentiate it is by the pathologic type, which is either lobar, bronchopneumonia, interstitial, and these two. Now, for lobar pneumonia, it's usually caused by strep pneumonia. Okay, other than that, you have Legionella, Klebsiella, whatever. Bronchopneumonia is just basically this infiltration, this consolidation in multiple areas. Atypical pneumonia or interstitial are caused by the bacteria that we cause. It causes diffuse consolidation. Okay. This, ignore it. Aspiration pneumonia, typically seen in elderly patients who are stroke patients, most probably in the hospital, and they have aspiration. Another thing is alcoholics. Okay. So that's basically that. This is basically the slide. Now, very important for you guys is identifying the causes of pneumonia. You have this patient who's presenting to you with signs of lobar pneumonia, typical pneumonia, has a fever, cough, productive cough with sputum, and the sputum is rusty sputum. What is it? Good. Strep pneumo. What type of organism is strep pneumo? Is it gram-positive or negative? Basic micro. Positive. Is it a cocci or rod? Cocci. Is it in chain or cluster? Chain. Good. Okay, and it's usually lancet shaped, as they describe it. Strep pneumo. You have an alcoholic presenting to you with signs of pneumonia. This is their sputum. Klebsiella pneumonia. What type of organism is Klebsiella? Positive or negative? Negative, good. Okay, this is what we call the current red sputum, okay, or the red jelly sputum, okay? Memorize these two sputum samples, okay, as disgusting as it is. These will come in the exam, okay? Now, you have a patient who comes to you with a repetitive infection, pancreatitis, you do chest CT, they have bronchiectasis. Pseudomonas, good. What's the underlying cause? Cystic fibrosis, good. Now, Pseudomonas auxiliary is positive or negative? I believe it's positive. Okay, it's positive. Pseudomonas is oxidative positive. That's okay. Now here, why is it green? Why is the sputum green? The dyes from the organism. They have many, Pseudomonas has 3 dyes, which is pyocyanin, pyoverdin, pyogranin, whatever. These dyes colored green. So this is Pseudomonas. Again, the common association is with cystic fibrosis. Now, pathology related is you need to know the basically stages of pneumonia and pathology. Now, day 1, day 2 is basically presenting with congestion based on what is causing the congestion is the bacteria, some red blood cells as well, then the neutrophils and so on. Later on, you have red hepatization, which is basically the same thing, but just more congested. And because of the amount of RBCs and bacteria that there is, this is going to cause it to become red. Okay? When these red blood cells and so on gets destroyed and lysed, it becomes gray hepatization. Okay? Which is lysis of the RBCs. This is day 5 to 7. After that, you have resolution, which is, you can see fibrosis maybe. Okay? These stages are important, okay, to remember. From these, this day is the most important for you to remember, these 2 days. Day 5 to 7, gray hepatization. Why is it gray? Is because they have lysed RBCs. Now, why is it called hepatization? It looks like the liver. Okay, the lungs will now look like the liver. Now, what stage of pneumonia is seen here? You have red cells here with a bunch of neutrophils and so on. What stage of it is it? Now, the first 2 stages, I'll give you a hint. It's a bit of a overlap between them because it's the same thing, but just the next one is worse, which is basically this, red hepatization, or I'd give you congestion, okay? What is causing the congestion, or what is congesting? Congested capillaries, which is a bunch of red blood cells, and neutrophil exudation, okay? How about here? Good. Gray hepatization. What is the cause of gray hepatization? Lysed RBCs. Good. And this is usually day 5 to 7. Okay. How about here? Resolution. Good. Which you can see, or organization, which is you can see fibrosis. This is day 8 and beyond. Okay. So all of this is the resolution areas, okay, organization areas with fibrosis. Now, the gold standard way of diagnosing, or the best way we can diagnose pneumonia is, yes, resolution, organization, same thing, is X-ray. Other than that, what will give you the definitive organism by doing what? Culture of what? Sputum, good. Sputum culture will give you the definitive organism. To diagnose pneumonia, the best thing we could do is X-ray, you guys mentioned. Now, X-ray, what will you see on X-ray for pneumonia? What is the finding that we see in X-ray? Give me the broad finding. Consolidation, good. Now, consolidation can be lobar or bronchopneumonia, okay, which is diffuse consolidations. We'll go over it. Here you have consolidation. Where, can you tell me which lobe is involved? If you guys can, that'd be amazing. It's left lung. Is it upper or lower? This is lateral view. This is the septum. Lower, okay? From here, how can you tell that this is lower and not upper? Other than the diaphragm. Obviously, it's going to be near to the heart, but the most thing that I want you to remember out of this is the heart border. If you can see the heart border clearly, this is lower lobe. Okay? If you can't see the heart border, what do I call this? A specific sign, which is called the silhouette sign. Silhouette sign. Okay? Basically, if it's, I'll show you the next picture. If it's the consolidation blends with the color of the heart, but I cannot see the border of the heart, it's most likely coming from something called the lingula. What is the lingula? It's that piece of the upper lobe of the lung, which is indicator of upper lobe, left upper lobe pneumonia. Okay. Will you guys get this? I highly doubt. Okay. But what I want you guys to remember is in consolidation, why is this not atelectasis? What is it that's differentiating this from atelectasis? I'll give you a hint. What do I call this? I can see the airways. So what do I call this? This is what I call air bronchogram. Here's another image of it. Okay. Air bronchogram basically tells me that there is consolidation and not atelectasis. Okay. Another thing is silhouette sign. If I see a silhouette sign, this is consolidation, not atelectasis. And I'll show you atelectasis. Can you clearly differentiate basically that lower and upper here? Like, is there a clear border other than if you do lateral? Not really. If you see atelectasis, there is a clear differentiating mark between. This is left lower lobe consolidation, pneumonia. You guys already mentioned immediately it's consolidation. It's left lower lobe. How about here? Left upper. What is this sign called? Can I see clearly the border of the heart? Can I demarcate it perfectly? No, not really. So this is upper or lingula, okay, which is part of the upper lobe of the left lung. طيب. This is what I call left upper lobe consolidation. If you get this, but you can see the heart border, what would I call this instead? And there's no air bronchogram. If there's no air bronchogram, no silhouette sign, but but it's upper, what do I call it? Patient had a collapsed lung. Atelectasis. If they have a picture of pneumonia, you do an X-ray, you see silhouette sign plus air bronchogram, consolidation. This is the most important thing I want you to remember. How to differentiate consolidation with atelectasis. Other than that, you can see from a lateral view, which is the best thing we can do, as you can see clearly, this is the septum, and this is the upper, this is lower. It's clearly in the upper, okay? This is upper lobe consolidation or lingular consolidation, okay? Do you guys understand the difference here with consolidation atelectasis and upper and lower? Or do you want me to repeat something? Because I know radiology, especially in CVP, is annoying. Okay, good. How about here? Diffuse consolidation. Good. That's it. Okay. It's usually atypical. Yeah. Good. Now, for the management of pneumonia, it's very important to remember these two scores, not in detail, but just know about it. Okay. So you have curb and the pneumonia severity index. For curb, it's called curb 65. It looks into 5 parameters. Firstly, is a patient confused or not? Is the urea above 7 or not? Is his respiratory rate above 30 or not? Is the blood pressure low? And if their age is above 65. Why is this important for us? Is to know where to send the patient. Okay? If, for example, the patient does not have confusion, urea is 5, respiratory rate is 20, blood pressure is 120 over 80, age, he's a 30-year-old. What score does he have? 0. If they have pneumonia, would you send them home? Yes. Okay, because they're fine. They'll recover. Just give them antibiotics, go home. If they have confusion, high urea, respiratory rate over 30, in shock, blood pressure is low, and their age is 7-year-old, would sending them home be a good idea? Not really, because they're in a critical state, especially if their blood pressure is very low. So we send them to the ICU, intensive care unit. This is just important for us to where to send the patient. If they have, for example, 0 to 1 score with the curve 65, send them home. 2, outpatient. What does outpatient mean? Or sorry, not outpatient. Basically admit them to the hospital in something that we call wards, okay? Which is basically normal patient rooms in the hospital, not the ICU. You admit the patient just for surveillance, and you give them antibiotics. Here, 3 or more these parameters, you have to admit them to the ICU because they are critical. Okay, they are severe like severe pneumonia patients. Okay, that's basically that. The reason is because again, if they have any of these, they are in more severe states of pneumonia. Okay. Now for respiratory severity index, it's another one that we use. Usually we use this, okay, the curve 65. But here, just remember, if it's above 91 points, this is inpatient treatment. Other than that, it's outpatient. Outpatient means home. Inpatient means admit to the hospital. Okay, that's basically these two. Now, if the patient has a curve, for example, of 0 to 1, you treat them outpatient, home. What medications do you want to give? Usually it's monotherapy with either amoxicillin or a macrolide. The macrolide is usually azithromycin or clarithromycin, or you want to use doxycycline for what type of organisms? Atypical, usually. Okay? Doxycycline can cover them. Other than that, you use this. For this lecture, they go into detail about the mechanism of action and the side effects. Just cover them. Okay? Azithromycin, clarithromycin, macrolides, some of the features of macrolide, for example, side effects, for example, in the heart, the liver, and so on. Okay? So just cover those from the lecture. But for me to you, what you need to know is you usually give them one of these drugs. Okay? Now, if they have a more severe profile, which what does that mean is they have, for example, other diseases, comorbidities, put them at risk for more severe pneumonia, you usually want to give them other medications, such as a respiratory fluoroquinolone. Good. Okay? You want to start them on this. And it's usually either a combination therapy of these two, or use the monotherapy with respiratory fluoroquinolone. Now, something I want you to remember is for fluoroquinolones, if you're trying to cover Pseudomonas, you have to use 3rd generation. Okay? So ciprofloxacin can cover Pseudomonas. Other than that, you can use fluoroquinolones. What are side effects of fluoroquinolones? For example, in the heart, QT prolongation. Okay? So that's basically for this set of patients. Severe, you want to, same thing. Combination of anti-pneumococcal beta-lactam, one of these, plus a macrolide. If you're suspecting atypical pneumonia, give doxycycline, monotherapy with a fluoroquinolone, or combination with beta-lactam, with these 3rd and 4th generation fluoroquinolones. Okay? That's basically pneumonia management. This lecture goes into detail about stuff that you learn from POD. Okay? So just revise those and expect the unexpected with this lecture. Okay? But inshallah, the questions that you get is simple as what I mentioned. Now, you have a patient with a history of they just recently traveled or they moved from an endemic area, came to work here, and they're presenting to you with a history of night sweats, chronic cough. What is this? Weight loss, TB. Good. Mycobacterium tuberculosis. Good. Now for Mycobacterium tuberculosis, you want to do pathology. What do you do? What do you see in pathology? What do you see? Granuloma. What type of granuloma? Caseating. Good. Now, if you do staining, if for example, sputum staining, what is a stain called? Zil-Nelson, good. What type of organism? Like color, or acid-fast organisms, okay? Good. Now, very importantly is recognizing TB on X-ray. What do I see on X-ray for TB? What are these lesions called? You can, what are these that you can see? Cavitation. Excellent. Someone mentioned no air fluid levels, which is very good. We'll talk about this later. A cavity. Cavity is filled with air. Okay? So you won't see fluid in it. A very big hint for later. This is usually in secondary latent TB later on. Okay? Not in primary TB. Now, TB has stages. You first have the infection based on your exposure. Now, you have primary TB. Primary TB can either recover simultaneously or go into latency or go to secondary TB. Now, when you have latent TB, it lays dormant in these granulomas because of macrophages, okay? That's basically latent TB. You're infected, but you're not symptomatic. It's just there. But you can spread the disease. Then you have secondary TB, which you have reinfection again. Now, for primary and secondary TB, you have a risk of something called miliary TB. What is miliary TB? It is dissemination of TB all over the body. So, for example, it can affect the vertebra, causing something called Pott's disease, and we'll cover this 2 blocks from now, inshallah, in MSI. But Pott's disease is one. It can spread to many, many different organs. That is miliary TB. Okay, and it's a complication of either primary or secondary TB. Good. Now, for TB itself, how does it do its thing? Very importantly, just remember that macrophages, it basically keeps it inside macrophages. An important virulence factor that TB has to escape macrophage function is something called cord factor. Okay? Just memorize this statement. Other than that, what causes the granuloma formation? TNF-alpha. All right? That's basically TB pathogenesis that you need to remember. Everything else is, I don't think it's too important. Okay? This I just mentioned basically. You have primary TB or primary complex can go latent or can go to progressive TB, which can spread to miliary, or you have reinfection into secondary TB, and this causes the cavitation. Okay? And miliary TB just disseminates everywhere. There's a picture in your slides of spleen having TB, for example, complexes. That's basically miliary TB. Okay? Now, very importantly for you to remember is how to treat TB. Okay? What are the drugs we give for TB? Give me the, ripe medication. What's R? Rifampicin. What's I? Isoniazid, INH. What's P? Pyrazinamide. What's E? Ethambutol. What other medication can you give? What's the 5th medication? Streptomycin. Good. Do you have second-line agents? Yes. Do you need to know them? Not really. Okay? That's it. You need to remember these 5. Let's go over them one by one. So first on, you have rifampicin. Now, for TB, you want to inhibit 2 things. Either you inhibit the inside the RNA or you inhibit cell wall, one of them. And then you have a drug that we don't even know what the mechanism is. So anyways, to inhibit the cell wall, you have 2 drugs. Isoniazid, ethambutol. Let's start with isoniazid. For isoniazid, INH, they basically inhibit the synthesis of mycolic acid. Okay? The specific, it's a prodrug. It requires something in the TB to activate it. What is that thing? What is that gene? It converts INH to its active form, CAT-G, good, which is a catalase peroxidase enzyme. It encodes for it. This CAT-G gene, it has to be present in the TB, okay, to convert isoniazid to its active form. How can TB have, for example, resistance is mutation in CAT-G. That's it. So isoniazid will not be active anymore. Okay, that's the main mechanism of action. Inhibits mycolic acid, requires CAT-G, the enzyme catalase peroxidase, to activate INH, isonize it to its active form. If you have mutations in CAT-G, you have resistance. This drug will not work. Very importantly, is in isoniazid, what vitamin deficiency will you have? B6 pyridoxine. This is why in these patients, you have to give them B6. If you're giving this drug, you give them B6. That's basically that. You need to give them B6. Now, B6 deficiency causes neuropathy, sideroblastic anemia. You'll cover this next block, hepatotoxicity, and so on. And it's one of the drugs that actually causes drug-induced lupus. What other drugs can cause drug-induced lupus that we covered last crash course? Hydralazine, and one more, if I remember. Procainamide, excellent, good. Good. Okay, this is the third one that you want to remember. Good. So that's basically isoniazid. Now, the next drug to inhibit cell wall is ethambutol. Ethambutol basically inhibits arbenosyl transferase, which basically decrease arbenogalactan, which is in the cell wall, so it decreases cell wall synthesis. The most important thing to remember about ethambutol is what side effect? Optic neuropathy. Good. How can you check for optic neuropathy? The most important thing or characteristic finding these patients will complain of. Visual acuity and red-green color changes. Good. So children, can you give like this drug? Will they be able to? Yes. Okay, good. No, you do not give them because they won't be able to tell the difference. Okay, it's subjective. Good. Children will tell you something green, but it's actually blue, and you won't know. Okay, because they don't know either. So that's why ethambutol, you typically don't give it to children under 6 because it's very subjective. That's ethambutol. Okay. Now to inhibit microRNA synthesis, you give them rifampicin. Okay, that's basically the mechanism of action. How does it work? Is it inhibits RNA polymerase. Okay, so if you have a mutation in RNA polymerase, you have resistance. Very importantly is if you give rifampicin, what is the most characteristic side effect that they will always complain about? Body fluids becoming orange red. They will come to you in emergency telling you, oh my God, for example, urine turned red. What's happening? You take history, they're taking rifampicin. Done. You already know why. Okay? That's typically the most tested side effect. Yeah, it's a very good sign that they are compliant. Very true. Other than that, it's very hepatotoxic. Okay, so it's hepatotoxic, so you monitor them with the LFTs, okay, liver function test. What other drug in CVP do you want to monitor with LFTs? If they have dyslipidemia, what drugs do you want to monitor LFTs with? Statins, good. I'm going to throw these random questions now since we're almost at the end. Now, pyrazinamide, the mechanism is uncertain, causes hepatotoxicity and hyperuricemia. Okay, so that's basically that about it. Streptomycin, protein synthesis inhibitor, autotoxicity and nephrotoxicity. What you need to remember are these specific side effects, such as this. Okay, know the mechanism and peripheral neuropathy because of the B6 with INH. Know these side effects, know their mechanism, and know their cause of mutation. The most important one for mutations is this CAT-G. This is a very important one. Other than that, RNA polymerase. Okay, that's basically TB management. Are you guys good with micro and TB and all that stuff? We can move on to cancer. Good. Now, for cancer, as I said, there's two types of findings you see on X-ray or CT. It's a nodule or a mass. A nodule is less than 3 centimeter, mass is above 3 centimeter. Okay. Now, do you need to tell the difference typically by looking at the image? No. So if you say nodule here, if you say mass, I'll accept it. Now, this is basically gonna be either a nodule or mass. I wrote nodule here, but whatever. Which one, this one, or the one that I have two, is most likely to be malignant? One or two? One. Can you tell me why? Borders. Excellent. That's number one. Number two. Okay, good. So I want to look at two things, or more than two things, but I'll explain it. In this image number two, this over here, this line, what is this line? This line is the septum, okay? If it's with the septum, it's most likely to be benign, most likely. Other than that, look at the borders. The borders here is more demarcated, well demarcated. You can tell the borders, kind of, okay? So it's more likely to be benign. In malignant ones, can you identify that's on a septa, or is it just in the middle? It's just random. This is a malignant feature. Other than that, can you clearly demarcate a border? It's spreading everywhere? Not really. And the borders itself, if it's more rounded, it's most likely to be benign. If it's something like this, it's most likely to be malignant. This is what we call speculated borders in radiology. So this is speculated borders. Okay, this is most likely a mass. It's very big. It's probably more than 3 centimeters. Okay, but this is most likely to be benign. What I want to do with this, I'll take a biopsy. Okay, basically that. Now we go into actual images. Firstly, this patient is a smoker. Okay, so what type of cancer will develop here? We'll see. So first of all, is what's happening in image A. They are a smoker, and slowly stuff is happening. What is happening? Metaplasia. What type of metaplasia? No, not yet metaplasia also. There's something else. What are these cells? Firstly, what's a typical, what are the cells lining the respiratory tract? What is epithelium? So we can start basic. Ciliated columnar epithelium. Good. So are these columnar cells? Yes or no? Yes. Good. These cells are goblet cells. So goblet cells are increasing in number. So what do we call this? Goblet cell hyperplasia. Okay, done. Here, what you can see is there are basal cells everywhere. Typically, normal epithelium, the basal cells are dark, and then it gradually becomes lighter color. Okay? Here, the basal cells are everywhere. So what do I call this? Basal cell hyperplasia. Good. How about here? Here you can see what type of cells. This bottom image, or bottom part of the image. This bottom. Okay. Basically, what's happening is metaplasia. It's changing from columnar to these squamous cells. So you have squamous metaplasia. Good. So what type of cancer can they form if it's squamous metaplasia? SCC, squamous cell carcinoma. Good. Image D, what's happening? Dysplastic changes. Good. Perfect. Okay. You have the NC ratios increased. You have very dark nuclei. You cannot, for example, there's loss of differentiation to the surface, which basically means they're all one uniform color, which should not be the case, should be something like this, and increased thickness. So this is dysplasia. Good. What's happening here? There is this image. This is squamous carcinoma in situ. Okay. How about here? It invaded the basement membrane. You can see cells seeping into the, this is cancer. It's invasive squamous cell carcinoma. Good. Now you have this patient. What type of cancer do they have? Squamous cell carcinoma. Good. Let's take firstly the image. What can you see on the X-ray? Firstly, it's more central. This one is apical. It's in the apex. So if you have an apical cancer, what can develop? What can this patient develop if they have Horner syndrome? What do we call the finding? Pancoast tumor. Good. Pancoast tumor. If they have an apical tumor, which is a tumor at the apex of the lung, it can compress, for example, the sympathetic chain. It can compress, for example, the superior vena cava, can compress the brachial plexus, so they have arm pain. They have, if they, for example, compress the sympathetic going up to the face, they have Horner syndrome. Good. Another thing, can someone tell me what else can you see on this image that tells you that might be cancer? Tracheal deviation, excellent. And it's towards. Okay, why? Because of fibrosis. Most likely it's cancer. Good. Now I'll take the biopsy. What can you see on this pathology? Keratin pearls. How about this one? Intracellular bridges, or what else can I call it? Desmosomes, okay? This, can you see these small lines between the cells? This is intracellular bridges, okay? This is a keratin pearl. And then here's just squamous cells. So anyways, typically, this is in males. Pancoast tumor can be squamous cell carcinoma. Pancoast tumor just basically telling you there is an apical tumor that's causing Horner syndrome, SVC compression, so on. That's basically what's a Pancoast tumor. Pancoast tumor can be any tumor in the apex. Okay, good. Now squamous cell carcinoma, what's the most important risk factor for the patients? Smoking. Good. Now, can they develop a perineoplastic syndrome? What type? What can hypercalcemia? Why? What's causing the hypercalcemia? PTH-like peptide or PTH-RP related peptide. Okay, perfect. Yeah, PTH-related peptide or RP that causes hypercalcemia. Okay, good. This is the perineoplastic syndrome that's associated with it. Good. Now, this most common cancer, typically, is this. What is this? Peripheral, not central tumor. Adenocarcinoma. What is the most common cancer develops in females, non-smoker? Adeno. Remember this. Female non-smoker, adeno, usually. Good. This is adenocarcinoma. Again, tracheal deviation, shifted towards the tumor. Why? Because of fibrosis. Good. Now, what are these telling you? It's adenocarcinoma. I'm just going to tell you that. Now, this image is a precursor to adenocarcinoma. What is this? Bronchoalveolar carcinoma in situ. Good. Good. Now, how about over here? What did I stain it with? TTF1, which stands for thyroid tissue factor 1. Okay. So here it's just telling you that there is mucin, because what do glands secrete? Mucin. And this is an adenocarcinoma, which means it's glands. Okay. Basically, it's showing you glandular, and you can stain it with mucin, which is positive. Okay. That's basically this. Oh, this patient presenting to you with Cushing's syndrome, SIDH, myasthenia-like symptoms, small cell. Good. Okay, small cell carcinoma, which is what origin? Neuroendocrine. So what markers will be present? What markers can you use to identify chromogranin CD56, I think? I forgot the number. And then there's others that the slide doesn't mention, such as synaptophysin and whatever. Okay, this is small cell cancer. This is CD56. Good. This is the least form or like least common cause from you have non-small cell, which is adeno and squamous, and large cell. Then you have small cell. More commonly is the non-small cell. From the non-small cell, adenocarcinoma is the most common. Okay. So for small cell, it's more lethal. It's more dangerous. Is it central or peripheral? Central. And what paraneoplastic syndromes are associated with small cell? Lambert-Eaton myasthenic syndrome, SIDH, Cushing's. Good. Perfect. Okay, that's basically that for small cell. How about this one? Large cell. Good. Big cells. That's basically everything you need to know for large cell. Just memorize the picture. Okay. Clinically or not clinically, MCQ, if they provide the images, you know. If they ask you anything in MCQ, it's going to be probably small cell, and it's paraneoplastic, it's going to be mentioned in the case. Most likely, they'll ask either the origin, neuroendocrine, or the markers, which is chromogranin A and CD56. Okay, or just they'll tell you that in the scenario and what cancer it is. Small cell. Dr. Shaukat is good with he's fair. Anyways, now you have this. Carcinoid. Is it syndrome or tumor? Tumor, good. Can this cause carcinoid syndrome? Yes, good. What is this embryological source of this? Same as small cell, neuroendocrine. Okay, so same markers even, synaptophysin, chromogranin, whatever. In terms of pathologic image, this is all monotone, which basically means that all the cells look exactly the same. Okay, this is a characteristic finding. Oh yeah, this is just carcinoid tumor, can cause carcinoid syndrome. Caused by what hormone gets released? Serotonin. What can you check for in the urine? To tell you that this is serotonin syndrome. What in the urine? 5-HIA. Good. Now you have this incidental finding in a patient who's completely normal. What is this? Many pictures that I provided because they can bring any of these, especially the radiology. Completely normal patient. Hamartoma. Good. Good. Hamartoma is just basically disorganized tissue in random places, okay? Which is collagens, usually collagen is the most important thing, calcifications and whatnot, okay? Most important images I want you to know is these two CTs. What can I call this nodule? What can I describe it as? Popcorn calcification. Good. There is popcorn calcification. Looks like a popcorn, okay? That's basically a hamartoma. All right, it's completely incidental. You can see the borders are smooth, circular. It's not spreading. These are good benign features. Good. This is basically what you can see in a hamartoma. You have a bunch of collagen, fibrosis, and like whatever, yeah, collagen, calcification, random tissues, basically everywhere. This is hamartoma, completely incidental, completely benign. And what? Okay, this slide is messed up. You guys are lucky, but you already mentioned it before. Pancreas tumor, tumor in the apex causing everything that we mentioned before. Now, what about this patient? He used to work as a plumber, then presented with this years later. Malignant mesothelioma, good. Okay. On the CT over here, I can see very thickened pleural, like severely, and most likely metastasized somewhere. Again, it looks way more disgusting than and damaging than asbestosis. Okay. Now, when you do biopsy, you have two variants. What is this variant of asbestosis? Or sorry, mesothelioma, sorry, not asbestosis. Epithelioid, this one. Which is epithelia and sarcomatous. Okay, good. Perfect. Memorize these two images. Mesothelioma, asbestos exposure. Oh, this patient. Let me tell you, it's a female with a breast cancer. You do this and you see this. What happened? Lung metastasis. Take it as a rule. You see multiple masses, for example, one here, one here, one here, one here. You see many masses in the lungs. This is what? Lung mets, okay? Metastasis. High yield images syndrome, okay? From somewhere else. Breast cancer, colon cancer, liver cancer, melanoma, all these cancers can spread to the lungs. Brain tumors spread to the lungs, okay? Is that. Now, for lung cancer therapy, there's a lot of things. Dr. Centers probably told you what to focus on, I think. But basically, it's targeted therapy. You want to inhibit the most important receptor is the EGFR, epidermal growth factor receptor. The way you inhibit this is by tyrosine kinase inhibitors, because EGFR itself is a tyrosine kinase. Okay. If you remember from mole back then, the types of signal transduction, this is tyrosine kinase, which causes autophosphorylation. You inhibit this by tyrosine kinase inhibitors, which are any drug that end with nib. Okay, so erlotinib or gefitinib. These drugs are high yield to remember for the exam. They bind to the tyrosine kinase binding to EGFR, which is the most effective way of inhibiting this. Now, in terms of side effect, rash. Just remember rash, and there's a lot of things, and Steven Johnson, which is a bigger, more severe rash. Okay, so that's basically this. Okay, and just read and understand the mechanism and how it binds and inhibits EGFR in terms of the tyrosine kinase. Now, you have the ALK kinase inhibitors, again, and ends with nib. Is it really important? I don't like, if he asks anything about these drugs, it's usually bevacizumab and erlotinib and gefitinib or the targeted therapy. So I won't go over this, but read through it. What I will go over is bevacizumab. Bevacizumab blocks angiogenesis, which is basically caused by VEGF, vascular endothelial growth factor. Blocking that will block angiogenesis, which will block tumor growth. Why? Because tumors usually secrete VEGF. They need constant blood supply. Inhibiting angiogenesis will kill the tumor. This is first-line therapy for advanced non-squamous non-small cell lung cancer, which is basically adenocarcinoma. Okay? In combination with chemotherapy. Now, bevacizumab, the most important side effect that I want you to remember and most commonly asked is hypertension. Okay, just remember hypertension. Other than that, it can cause so many things. Okay, because these drugs are very toxic. That's why we only give them in certain cases, in cancers and so on. And they're very toxic. Okay, just remember hypertension. Now, we can target, not targeted therapy, immunotherapy with using these drugs. Okay, what are immunotherapy? Is basically checkpoint inhibitors. You have PD-1, PD-1 ligand inhibitors, and you have CTLA-4. Okay, PD-1 inhibitors are, for example, nivolumab. PD-1 ligand inhibitors or PD ligand inhibitors are atezolizumab, and then CTLA is ipilimumab. Memorize just the names of these drugs and what they do. In terms of nivolumab, they bind to PD-1, not the ligand, and this basically allows the tumor to die from the T cells. Okay, So basically that, or no, this binds, what's it called? Basically PD1 ligand. PD1 is on T cells and so on. So what you do is you want to inhibit that to allow the T cells to kill the tumors. PD ligand is on the tumor cells, and basically it binds to the PD receptor to inhibit T cells. You want to inhibit either ligand or inhibit the ligand from binding to the receptor. That's basically that. And it has many side effects, as I mentioned. Again, these drugs, usually he asks bevacizumab and this, but he can bring anything, okay? But he most likely told you what to focus on. So that's basically the lung cancer therapy. Now, last set of things in this crash course is miscellaneous stuff I did not know where to put from those three, so it's just random stuff. Number one is hypoxia or hypoxemia. So you have anoxia, which basically means no oxygen. Hypoxia is low oxygen delivery to tissue, and hypoxemia is low oxygen in the blood. That's it. So what can cause hypoxia? You have 5 usual causes. Is firstly decrease inspired PO2, for example, obstruction or high altitude or something. Then you have hypoventilation, which causes respiratory acidosis. So when can you have hypoventilation is, for example, obesity, certain drug intoxications, and so on. Then you have diffusion limitation, which is seen in interstitial lung disease. VQ mismatch is when you have either a defect in ventilation or perfusion. Usually it's perfusion. So what can cause this? PE, pulmonary embolism. Okay. Lastly is a right to left shunt. This is most likely in cardiac diseases, the congenital ones that we covered. That's basically that. Just know it superficially. Okay, these things. Now this is from the clinical lecture. You have respiratory failure. There's type 1, type 2. Type 1 is hypoxemic. Type 2 is hypoxemia with hypercapnia. Hypercapnia is PaCO2, partial pressure of CO2, over 45. What I want you to remember is type 2 respiratory failure, which is hypercapnic, is associated with COPD. Remember COPD as a cause of hypercapnic type 2 respiratory failure. Okay? That's the point that I really want you to focus on. Other than that, there's many other causes. Now, what you might be tested on is the blood gas analysis. Because you have patients who can hypoventilate, hyperventilate, and this causes changes in their acid-base function. Now, what is the normal pH? It's 7.35 to 7.45. If it's less than 0.35, what is that? Is it acidosis or alkalosis? Acidosis. If it's above 0.45, alkalosis. Good. Number one thing is in any acid-base question, you look at this first, pH. So you can tell if it's acidosis or alkalosis. Number two is you look at this, PaCO2. If the normal is 35 to 45, if it's less than 35, it's hypocapnia, and it usually causes alkalosis. What type of alkalosis? Respiratory, because there is low PaCO2. This is usually seen in cases of hyperventilation. Okay? 45 and above, or above 45, this is respiratory acidosis, usually seen in hypoventilation, low ventilation. Okay? Then you look at bicarb. 22 to 26. If it's below 22, this is metabolic acidosis. If it's above 26, this is metabolic alkalosis. So now, number one thing you do is look at pH. Identify if it's acidic or alkaline. Then go from there. If you have acidic, if the pH is, now follow me, if the pH is 7.2, it's acidic, right? If the PaCO2 is 47, what's the cause of acidosis? PaCO2 is 47. Bicarb is 23. What's the cause of acidosis? Respiratory acidosis, which is usually hypoventilation. Excellent, good. Now you have a patient who has a pH of 7.3, okay? PaCO2 is um PaCO2 is 44 and bicarb is 20. What's the cause of this acid? What's the acid base? Metabolic what? Acidosis, good. If you have a patient with a pH of 7.36, okay, PaCO2 is 50, okay, bicarb is 21. Or yeah, 21. What's the acid base abnormality? This is a trick one. This is the most trickiest you can get. pH is 7.36. Actually, wait. The PaCO2, I'll change it. It's 34. The pH is 7.36. PaCO2 is 34. Bicarb is 21. Yes. So what's causing the slightly low pH? Metabolic or respiratory? Excellent. Metabolic acidosis with compensation. Why do you say metabolic? Is bicarb is low with the pH. It's low normal. This is more chronically. So what's happening here is in acute metabolic acidosis, there will be acidic pH, so it will be below 0.3, but bicarb is going to be below 22 because that's what's causing the metabolic acidosis. What will your body do to compensate? Is hyperventilate to try to release as much CO2 as possible. So the CO2 will be alkalotic. Does that make sense? You're compensating. Good. If the CO2 is also high, then you have both metabolic acidosis and respiratory acidosis. This is what we call compensation. Okay. Let's take examples, actual written examples, and see. So the pH is 7.42. Step one. Is this a normal pH? Yes or no? Yes. CO2. What do you do in step two? You look at CO2. Is the CO2 normal? Yes. Then you look at step three is look at bicarb. Is it normal? Yes. Step four is you identify, is it metabolic or respiratory? In this case, is there anything wrong? No. So you can say it's normal. So everything is he hypoxemic? No, خلاص. No hypoxemia. Good. Step five is check for compensation. Okay. How about here? pH. Normal, low, or high? Low. So what can you call this? Acidosis. CO2. Step two is CO2. High. Good. Before you say that this is respiratory acidosis, you look at bicarb. Bicarb, is it normal? Yes. So what can you say step four is? Respiratory acidosis. Good. Is there compensation? No compensation. Bicarb is normal. Good. Step six, is there hypoxia? Yes, خلاص. Good. Good. Now, what can you see in these cases? All of them. Don't tell me specific, just broadly. What are these 10 showing you? I'll clearly point it out. What are these? Not pneumonia, the other one. Not consolidation, atelectasis. Why is it atelectasis? Two things. If you see here, it's completely white out. Okay, collapse lung. Okay, in a collapsed lung, you will not have any air bronchogram. Number two is, can you clearly tell the hard border here? Yes. So negative silhouette sign. Same thing here. This is the entirety of that. Okay, of the atelectasis. Okay. Another thing is you can tell the clear line of demarcation between the tissues. Here it's a bit less clear, but this is atelectasis, and I mentioned the differences in the previous slides. This is basically showing you all the locations for atelectasis, but what is atelectasis anyways? It's collapsed lung, okay? This collapsed lung will be covered by something else, okay? Something else will come to fill up the space. That's why it will appear as white. That's it. Cause of it has many causes, and you don't need to go into detail. But radiologically, this is what atelectasis will present as. Now, tell me, what is this image? Image 1. It already has it in it, but this is abscess. What is this image? TB. Why is this TB and why is this abscess? What does abscess have? Second is cavity. Good. First one. What does abscess have that will tell you that this is an abscess? Fluid. So if there's fluid and you're telling the patient to stand up while taking an X-ray, where will the fluid go? On the base of the cavity. Down. So you'll see air fluid level. Yeah, that's it. Fluid will be down, air will be up. Abscess. Cavity, there's no fluid. So all air. That's it. This patient pneumothorax. Good. Excellent. In the left or right lung? Left. Good. Is this a simple pneumothorax or tension? Simple or tension? The difference is, I'll tell you the clue. Simple pneumothorax is a two-way valve. Air will come into the pleural space with inspiration and air will move out with expiration. Okay? Tension, air will move in but will not move out. So what's happening here with this patient? Is the heart supposed to be here in the middle? Yes or no? No, it's supposed to be here somewhere. But what's happening? Air is pushing it. Would air push it in simple pneumothorax this much? No, because there's a two-way valve. So this is a sign of tension pneumothorax. Good. Another feature. Can someone show me or tell me what is another feature of tension pneumothorax in this patient? I'll show you something. This is supposed to be the midline. So what is the defect? Trachea. Good. There is tracheal deviation. Okay. Is it towards or away in tension? Away. Good. So you can see it's away. This is the trachea right here. It's away from the midline. Okay, this is tracheal deviation. Other than that, look at the right border of the heart. It's very pushed away. Okay. So this is a tension pneumothorax most likely. And in this case, it's more severe. Why is tension pneumothorax severe? Is in tension pneumothorax, air will move into the pleural space but cannot move out. So it will cause compression. Most important compression, the heart and the blood vessels. So it causes cardiopulmonary collapse. The patient will be in shock, hypotension, tensive, low heart rate, whatever. How do you manage them? Stick a needle and relieve the air. Okay, then do other management, which you don't need to know. So this is pneumothorax. How about this patient? What do they have? Good. Pleural effusion. Right or left? Opposite. Right. This is right. عادي. But flip. This is the right, this is the left. So this is right. Pleural effusion. It's good. Okay. Blunted costophrenic margin. These most likely will not come, unless in case I put them. Tell me what this image shows. There's air under the diaphragm. So this is most likely something that we call pneumoperitoneum. Okay. How can I tell that this is air under the diaphragm? Let me take this image here. Here, look at the diaphragm on the right side. What's right under the diaphragm here? What's right under it? What organ is right here touching the diaphragm? Liver. Good. There's no space between the liver and the diaphragm. So if there's air, this is most likely something that we call pneumoperitoneum, air in the abdomen. Okay. Here on the left side, it's less, we don't really look at it in the left side. Why? There is still air. You can see there's air here because of the stomach, the gastric lumen. Okay. Anyways, this is basically a sign that there's some perforation in the GI. Okay. Don't worry about this. I doubt it will come, but it's very specific and it might throw you off if they bring it as a throwaway question. Here, it's a bit of a good. What type of hernia? Very good. This is a congenital diaphragmatic hernia, which is basically the diaphragm, some defect in the diaphragm, all the abdominal contents goes up to the chest space. This is repaired surgically. Okay, so this is congenital diaphragmatic hernia. And with that, I conclude this crash course and this session. Do you guys have any questions at all? And please scan this for feedback. Is everything clear? Do you want me to repeat anything? Any questions? Anytime. My contact is in the beginning. If you have any questions or concerns, feel free to contact me. Anyways, best of luck on your exam.